You know, if your laptop starts acting up, you can usually find a troubleshooting guide pretty easily.
Oh, absolutely.
Yeah, you just press Control-Alt-Delete or, I don't know, check the battery, open the activity monitor. It's highly logical. You know exactly what hardware is running what software.
Right, because it's a closed system built by humans. For
Mhm.
humans, it makes total sense. It's comforting because the mechanisms are entirely visible.
Exactly. But then you look at the human brain, the ultimate supercomputer. And if you're like feeling inexplicably sad or you can't remember where you put your keys or your heart is suddenly racing for absolutely no reason, there's no simple Control-Alt-Delete.
Definitely not. No neat little error codes popping up.
Right. Which is exactly why today we are taking your stack of clinical preparation notes on neurobiology and psychopharmacology, and we're translating them. We want to make an accessible, fascinating owner's manual for the human brain.
I love that framing.
Yeah, we are going to explore how microscopic, completely invisible chemicals dictate our massive, everyday human experiences. And here's where it gets really interesting. We are going to learn that the way we treat the mind is actually by hacking the body.
What's so fascinating here is that to understand the mind, we really have to demystify the biology first. We aren't just going to sit here and list anatomical terms.
No, nobody wants a textbook reading.
Exactly. We are going to synthesize the what with the why. Connecting the dots between physical brain tissue, the exact mechanisms of the medications, and the thoughts you have every single day. Because frankly, you can't fix the software if you don't know what machine it's running on.
Right, so let's pop the hood. Let's look at the physical hardware where all these reactions actually take place, because your brain has very distinct physical regions. Let's start right behind the forehead with the frontal lobe.
Ah, yes, the big one.
Yeah, this is the center for personality, behavior, impulse control, judgment. I like to think of the frontal lobe as the brakes on a car. Without it, we act purely on impulse, going 0 to 60 on every stray thought.
That's a perfect analogy, actually. And we see this mechanically when the frontal lobe is damaged,
Yeah,
say by a traumatic brain injury in a car accident.
like the biological brakes just physically fail.
Exactly. The result is intense irritability, aggression, and this profound disinhibition. And disinhibition literally just means acting without a filter. The person might suddenly start swearing at a loved one or getting into physical altercations.
Wow, just a total shift in personality.
Right, but it's not that they've suddenly become a bad person with malicious intent. It's literally that the neurological tissue responsible for pausing and evaluating a thought has been destroyed.
So it's a mechanical failure of the braking system. That's wild. But what about archiving the journey? Like if we move deeper into the brain, we hit the hippocampus, which is entirely responsible for converting short-term memory into long-term memory.
The brain's filing clerk.
Yes. So if I meet someone at a party, the hippocampus is what decides if I'll remember their name tomorrow. It takes immediate experiences and files them away into long-term storage.
Precisely. And if you sustain damage there, like a professional boxer suffering repeated concussions over a career, you get severe short-term memory loss.
Right, because the clerk is gone.
Exactly. The files from, say, 1995 are completely safe in the cabinet because they were stored years ago. But the clerk whose job it is to put today's files into the cabinet is missing. So you can remember your childhood perfectly, but you cannot remember what you had for breakfast.
An archiving issue. That makes total sense. And right near that filing clerk is the hypothalamus, which is the body's master thermostat. It regulates body temperature, but it also controls hunger, thirst,
Very important piece of hardware.
So here's my question for you. If the hypothalamus is the body's thermostat, what exactly happens to the rest of the physical house when that thermostat gets stuck on high heat during a traumatic event, like in PTSD?
That raises a really important question. And the mechanism behind it is central to understanding trauma. So, in a healthy brain, a threat appears. Say a car swerves into your lane.
Right, instant panic.
The hypothalamus instantly triggers a flood of adrenaline and cortisol. Your heart rate spikes, your pupils dilate, your sympathetic nervous system completely takes over to keep you alive. And once you're safe, the hypothalamus recognizes the threat is gone and turns the thermostat back down.
The hormones just recede.
Right. But in post-traumatic stress disorder, that regulatory feedback loop is fundamentally broken. the hypothalamus becomes chronically overactive.
So it's just constantly dumping those survival hormones into the bloodstream.
Exactly. It constantly triggers intense fear, rage, hyperarousal, even when the person is just, sitting safely in their living room. The biological alarm bell is physically jammed in the on position.
Man, it's exhausting just thinking about the physical toll of living with that tooth engine 24/7. Now, to round out the hardware, we have the brainstem, which acts as the autonomic autopilot.
Right. The midbrain, pons, and medulla.
Yeah, it controls vital life functions like breathing and heart rate without us ever having to consciously think about it. And hanging out at the back is the cerebellum, handling muscle coordination and
Yeah.
balance.
If you're walking down the street or dancing, your cerebellum is running complex spatial calculations to keep you upright. So that entire collection is the hardware framework.
But hardware doesn't do anything without software. These brain structures don't just sit in silence. They communicate using a highly specific electrochemical language, right? An electrical spark travels down a neuron, and then chemical messengers, neurotransmitters, cross the microscopic gap to deliver the instruction.
That's the perfect way to look at it. If the structures are hardware, neurotransmitters are the software code.
And just like a computer, if the software code is buggy, the entire system glitches. Psychopharmacology targets these specific neurotransmitters to basically rewrite the code manually.
Exactly, to stabilize the whole system.
Okay, let's unpack the software. Let's look at a few of the major players. First up is GABA, the brain's main inhibitory neurotransmitter. It actively decreases neuronal excitability. I kind of picture GABA as a heavy, weighted blanket that calms down overactive neurons.
A weighted blanket for the brain.
Mm-hmm.
That is an incredibly accurate visual. When GABA is doing its job, the electrical firing is measured and calm. But if GABA levels drop too low, those neurons lose their insulation.
They just start firing uncontrollably.
Right, pinging off each other in a chaotic cascade. And the severe physical consequence of that missing inhibitory blanket is a seizure. Without GABA, an electrical storm just overtakes the physical brain.
Wow. So GABA shuts the system down when needed. But what happens when the brain's emotional buffer wears thin? That brings us to serotonin. We usually hear about serotonin as the happy chemical in commercials.
Oh yeah, highly oversimplified.
Right. Because the reality is much more intense. Low levels of serotonin aren't just about feeling a little sad. They are directly linked to physical aggression, severe impulsivity, hostility, and even self-harm behaviors.
Yes, because serotonin is a massive regulator of emotional stability. It keeps compulsions and intense emotional swings in check. It's basically the guardrail on your emotional highway.
I like that. The guardrail.
Right, and when serotonin drops, that guardrail disappears, leaving the person highly vulnerable to erratic and sometimes dangerous behavioral spikes.
Which brings us to dopamine. Now, dopamine is famous. Every tech guru online talks about dopamine detoxes. It's known as the reward chemical. You know, what fires when we eat sugary food or check our phones.
Or fall in love, yeah. It also heavily controls physical movement, which is why a severe lack of dopamine causes the physical rigidity we see in Parkinson's disease.
But I have to push back here. Dopamine is universally famous as the reward chemical everyone wants more of. How can having too much of a good thing completely detach someone from reality and cause severe psychosis or schizophrenia?
Well, to connect this to the bigger picture, we really have to correct the popular understanding of dopamine. It isn't just about reward or pleasure. Dopamine is actually the chemical of salience.
Salience. What do you mean by that?
It is the brain's way of assigning meaning and supreme importance to a stimulus. Like, if you find water when you're dying of thirst, dopamine surges, telling your brain, pay attention to this. This is vital for your survival.
Okay, so it highlights what matters.
Exactly.
Yeah.
But in conditions like schizophrenia, where dopamine levels in certain pathways are abnormally high, the brain starts assigning that massive level of life or death importance to everything.
Wait, everything.
Everything. A random car driving by, a normal shadow on the wall, a stranger glancing at you. The excess dopamine floods the system and tells the brain, this is a direct threat. This is a secret message meant only for you.
Oh, wow. That overassignment of meaning creates severe delusions.
It fundamentally breaks the brain's ability to filter reality.
That makes so much sense. It's not that they are imagining things out of nowhere. Their brain is physically tagging meaningless data as highly critical.
Wow, it's terrifying, really.
Now, the last major software piece here is acetylcholine. It's vital for memory and muscle movement. And there's this fascinating disease that illustrates this, Myasthenia gravis. It's an autoimmune disorder where the body actually attacks its own acetylcholine receptors.
Right, think of acetylcholine as the key that turns the ignition for your muscles to contract. The brain sends the electrical signal, acetylcholine is released, and it plugs into the receptor to make the muscle move.
But in myasthenia gravis, the immune system has destroyed the ignition slots.
Exactly. The chemical key is there, the brain is shouting, "Move!" but the muscle simply cannot receive the message. The result is extreme muscle weakness that gets worse the more the person tries to move.
So knowing exactly how these software keys and receptors glitch is what allows medical professionals to step in, which transitions us perfectly to the rules of psychopharmacology, because hacking the system isn't just popping a pill and being cured.
Far from it.
There's a structured process, starting with the acute phase. I look at this like putting out a raging house fire. The singular goal is controlling the immediate severe symptoms and keeping the patient safe.
That's exactly it. You aren't worried about the paint color yet. You're just extinguishing the flames. And once the crisis is managed, you enter the stabilization phase.
Which is assessing the structural damage, right?
Yeah, right. You meticulously monitor target symptoms to see if the drug is actually working, while rigorously monitoring for side effects. You're tweaking the dosage to find the exact therapeutic sweet spot.
And finally, the maintenance phase, which is fireproofing the house, preventing a relapse over the long haul. But to do that, you have to understand how the body processes the chemicals. Let's talk about efficacy versus potency.
Two crucial concepts.
If I have a splitting headache, drug A might cure it with just 1 milligram. Drug B might also completely cure it, but I need 10 milligrams to get the job done.
They have the exact same efficacy, right? They both cure the headache.
Yes, efficacy is the absolute ceiling of what the drug can do. But drug A is much higher in potency because I need a significantly smaller dose to reach that maximum effect.
Precisely. Efficacy is the destination. Potency is how much fuel it takes to get there. But the real challenge in maintenance is how the brain adapts to that fuel over time.
Because the brain loves balance, homeostasis.
It's obsessively dedicated to it.
Mm-hmm.
If a medication is constantly flooding the synapse with serotonin to treat depression, the receiving neuron looks at that massive chemical flood and says, "Whoa, this is way too loud. This isn't normal." So to protect itself, it initiates receptor downregulation.
Okay, let's unpack this. Is receptor downregulation essentially like living next to a train track? At first, the noise of the train keeps you up all night. It's overwhelming. But eventually, your brain literally removes the auditory sensitivity. You board up the windows so you don't even hear the train anymore. Is the brain physically boarding up the windows to block out the medication?
That is exactly what happens on a cellular level. The neuron physically removes some of its own receptors from the cell surface. It literally boards up the windows.
Wow.
And when there are fewer receptors available to catch the serotonin, the therapeutic effect diminishes. This explains why an antidepressant might work beautifully for 2 years, and then it suddenly just stops working.
And this is different from tolerance.
Right. Tolerance is a slow decrease in effect requiring higher doses. Desensitization is a rapid, almost immediate drop in response. Downregulation is the physical removal of receptors.
The brain is literally fighting the very thing trying to help it. Which brings us to a massive realization. Hacking the brain isn't a perfectly clean science. Tweaking one chemical almost always creates a massive ripple effect across the entire body.
Oh, a profound ripple effect. You cannot isolate one system. Everything is connected.
Right, which means patient safety requires an incredibly delicate balancing act. Drug choice, constant monitoring, and even highly specific diet restrictions.
Let's look at the sheer biological danger of MAOIs for a second. They are a class of older antidepressants. They work by blocking an enzyme called marnoamine oxidase.
The security guard enzyme.
Right, normally this enzyme acts as a security guard, breaking down excess neurotransmitters like norepinephrine. By blocking the security guard, norepinephrine levels rise, which effectively lifts the deep depression.
But that same security guard enzyme also has a second job in the gut, right? It breaks down tyramine, a compound found in a ton of aged foods.
Yes, so if a patient on an MAOI eats foods high in tyramine like aged cheddar cheese, a glass of red wine, cured meats like salami, the tyramine isn't broken down.
It just floods the bloodstream.
It floods into the bloodstream, travels to the nervous system, and physically pushes massive amounts of norepinephrine out of the nerve terminals.
So it creates a catastrophic flood of adrenaline-like chemicals. The blood vessels constrict violently, and this is called a hypertensive crisis, right?
Yes, and it is a severe medical emergency. Blinding headaches, profuse sweating, heart palpitations, and even a fatal stroke. Literally just from eating the wrong type of cheese at dinner.
So mixing an MAOI with a standard charcuterie board is essentially lighting a match in a fireworks factory.
It really is.
And the side effects of antipsychotic medications present an equally difficult tightrope walk. You have low-potency antipsychotics, which cause anticholinergic effects. What is the actual mechanism happening there?
Well, while they try to block dopamine in the brain, low-potency antipsychotics also clumsily block muscarinic receptors throughout the body. These control your parasympathetic nervous system, your rest and digest functions.
So you basically turn off the body's natural secretions.
Exactly. You literally stop producing saliva, leading to severe dry mouth. Your digestive tract slows to a halt, causing intense constipation. The muscles controlling your eye lenses get lazy, blurring your vision. You dry the entire physiological system out.
But if you switch to high-potency antipsychotics to avoid drying out, you run straight into EPS, extrapyramidal symptoms, because high-potency drugs clamp down incredibly hard on dopamine.
And dopamine lubricates the motor pathways. Without it, you get a chemical induction of Parkinson's disease, a rigid shuffling gait, severe muscle spasms, unbearable inner restlessness.
And if you block that dopamine for too long, it leads to tardive dyskinesia, right?
Yes, the brain overcompensates by making the remaining receptors hypersensitive. This leads to completely involuntary repetitive movements, uncontrollable lip smacking or piano playing fingers, and tragically, it can become permanent.
So if doctors know high-potency drugs cause potentially permanent physical rigidity and low-potency ones dry your bodily systems to a halt, how do they even begin to choose which lesser evil to prescribe?
It's the fundamental art of medicine. It requires meticulously tailoring the choice to the individual's specific vulnerabilities. If a patient has a history of severe bowel obstruction, you absolutely avoid the low-potency drugs.
That makes sense.
If they are an athlete or prone to movement disorders, you avoid the high-potency ones, and you constantly monitor the blood work. For instance, the antipsychotic clozapine requires weekly white blood cell checks for 6 months.
Wait, it kills white blood cells?
It carries a risk of a granulocytosis. It literally signals the bone marrow to stop producing white blood cells, leaving the patient completely defenseless against basic infections.
It's all about managing biological trade-offs. Speaking of tightropes, look at lithium, the gold standard for bipolar disorder. It's an elemental salt, and the body processes it alongside sodium in the kidneys.
Right.
So if a patient gets the stomach flu or sweats too much and becomes dehydrated, the kidneys panic. They start hoarding salts to retain water. And because lithium looks so similar to sodium at a molecular level, the kidneys hoard the lithium too.
Which is why the therapeutic window is so dangerously narrow. Between 0.6 and 1.2, just a little dehydration, and suddenly your lithium levels spike into toxic territory, causing tremors, confusion, and eventually seizures.
Which is why lithium requires strict blood draws exactly 12 hours after the last dose. It is a constant, vigilant balancing act. We see a similar balance with anxiety medications, benzodiazepines versus buspirone. Benzos, like lorazepam, act fast, boosting that calming GABA blanket. But because they are central nervous system depressants, they cause heavy sedation and dependence. And the golden rule is absolutely NO, alcohol.
Because alcohol works on the exact same GABA receptors. If you combine a benzo and a glass of whiskey, you are doubling the suppressive effect on the brainstem.
And the brainstem controls breathing.
Exactly. Doubling down on GABA literally tells the brainstem to stop signaling the lungs to breathe. It causes fatal respiratory depression.
Terrifying. But buspirone avoids GABA entirely, right?
Yes, it acts slowly on serotonin, takes 1 to 2 weeks to kick in, but there is zero sedation and zero risk of physical dependence.
And all of these risks are magnified tenfold when we look at the aging brain and body. As we get older, our liver metabolism and renal clearance slow down. The filters aren't working as efficiently.
Right, so if an elderly patient takes a standard dose, it stays in their body much longer, vastly increasing the risk of accumulation. For older adults on benzos, the biggest safety risk isn't just breathing, it's falls.
The sedation combined with an aging body's fragility.
A simple trip on a rug becomes a life-threatening, hip-shattering event. The mantra is always, start low, go slow. And we also have to be vigilant about over-the-counter herbal supplements like St. John's wort.
Because they compete for the exact same liver enzymes that process prescribed psychiatric medications, causing toxic buildups. It is an overwhelming amount of chemical traffic to manage.
Truly overwhelming.
But as we start to pull back from the microscopic receptors in the liver enzymes, there's a concept that truly ties this all together. We've looked closely at the brain, but the brain isn't just floating in a jar. We have to zoom out to see how this neurobiology connects to the entire human body.
Which brings us to psychoneuroimmunology, or P&I.
Right.
It's a beautifully complex concept. P&I examines the direct physical links between the nervous system, the endocrine system, and the immune system. It proves that our behaviors and our emotional distress have a tangible impact on our immune health.
We often treat mental health and physical health as if they belong in completely separate hospital wings. But P&I proves they are running on the exact same plumbing. When the hypothalamus is constantly triggering the fight-or-flight response due to chronic stress, it floods the body with cortisol.
And over time, that constant hormone bath confuses the immune system's macrophages. They stop regulating properly, and overall inflammation goes completely unchecked.
This means that psychological stress physically leads to severe diseases like rheumatoid arthritis, heart disease, and inflammatory bowel disease.
The immune system literally begins to attack the body's own joints, all because the neurological alarm bell won't shut off.
So what does this all mean? It perfectly explains the harsh economic reality. The primary reason mental health care is so astronomically expensive isn't just the cost of therapy, it's because it is a long-term chronic condition that physically damages the rest of the body.
The cost of care directly reflects the systemic, whole-body toll the illness takes over a lifetime.
So why does all of this matter for you listening right now? Understanding these mechanisms isn't just a requirement for passing a clinical exam. It is the literal operating manual for your life. It explains the physical exhaustion you feel in your muscles when stress hits.
Absolutely.
It explains exactly why your older relative's medication regimen requires such intense vigilance and advocacy from you. It even explains how the aged cheese and wine you have at dinner can literally engage in chemical warfare with your neurochemistry.
And, if we step back and look at the sheer interconnectedness of it all, it leaves us with a truly profound concept to consider. We've just established through P&I that our thoughts, our chronic stress, and our mental states can physically alter our immune system, driving physical disease.
Right.
But what if we reverse that logic? If the mind can inadvertently break the physical body, could it be deliberately harnessed to heal it? Could the future of treating severe physical autoimmune diseases involve primarily psychiatric medications or intensive psychological therapies? Could we one day treat the mind as the primary avenue to cure the body?
Thank you so much for joining us on this custom deep dive. Keep asking questions, keep popping the hood to see how the wiring works, and we will catch you next time.